Hello, and thank you for joining us today for this OncLive Peer Exchange panel discussion titled Practice Update on Advanced Kidney Cancer. This program will feature insight focused on the specific information and educational needs of oncologists involved in the treatment of renal cell carcinoma and will include case-based discussions. My name is Dr. Robert Figlin, and I am the Steven Spielberg Chair of Hematology Oncology, Professor of Medicine and Biomedical Sciences, and Chief of the Division of Hematology Oncology and Deputy Director at the Cedars-Sinai Comprehensive Cancer Center in Los Angeles, California. Participating today on our distinguished panel include Dr. Thomas Hutson, Professor of Medicine and Director of Genitourinary Oncology at Texas Oncology, Baylor Charles A. Sammons Cancer Center, Dr. Eric Jonasch, Associate Professor in the Department of Genitourinary Medical Oncology, Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center, and Dr. David McDermott, Associate Professor for the Department of Medicine at Harvard Medical School, Staff Physician of Hematology Oncology at Beth Israel Deaconess Medical Center, and the leader of the Kidney Cancer Program at the Dana-Farber Harvard Cancer Center. Thanks to all of you for participating in this discussion. So, gentlemen, let's start by talking about the most important topic in kidney cancer in 2015 going forward, and that's the role of immune-based therapies. And David, let me ask you first, kind of put this in perspective for us. We know that immune-based therapies are now approved in melanoma, recently approved in lung cancer. We're excitingly awaiting data in kidney cancer. Help our practicing oncologists who sees kidney cancer patients to understand why is this class of drugs working, what are its mechanisms of action, and what are we hoping for?
So, Bob, for many years, those of us who've advocated the use of immune therapy for cancer have been struggling. We've sort of been wandering around in the desert trying to advocate for treatments that only worked for a subset of patients with a subset of cancers. Many of them were based on trying to drive the immune system forward, T-cell agonists that made T-cells more aggressive. So for example, cytokine-based therapies like interleukin-2 and interferon, which had effect in a subset of patients with kidney cancer, but they were associated with significant toxicity, and the folks who were getting a durable benefit with treatment was rather limited. But while IL-2 was proof of principle that you could get the immune system to fight cancer and produce a durable outcome, we struggled to understand why there was only a subset of patients who were benefiting. Over the last 10 or 15 years, there's been a growing understanding of why the immune system fails to deal with most cancers. And essentially, it's because from an evolutionary standpoint, the immune system is designed to shut off. When an infection is controlled, the immune system, the T cells, for example, are designed to shut off through these immune checkpoints, these pathways that will take an activated T cell and turn it down so it doesn't overreact against the body. Now we understand a lot more about these pathways and can target them, can essentially block them, whether it's CTLA-4, which is present on many activated T cells, or PD-1, which stands for programmed death 1, which is important on many T cells, particularly when they're in the periphery, near cancer cells. And when you can target these pathways with antibodies, you can activate T cells and help them kill cancer more effectively. And what's exciting about this field is not only are we seeing responses in kidney cancer and melanoma, but we're seeing responses in places where we've traditionally struggled desperately for immune therapies to work, like lung cancer. So now when you bring these PD-1 blocking antibodies into those settings, we're seeing response rates that are encouraging, that we've never seen before, where 20% of patients getting a major benefit, maybe another 20% getting a prolongation in stable disease. And when these agents have been brought comparatively compared to chemotherapy in melanoma and kidney cancer, we're seeing significant improvements in response. We're seeing progression-free survival improvements, early survival data that's very encouraging, and even more importantly, or as importantly, they're more tolerable, not only than our older forms of immune therapy, but then they're as tolerable or in some ways better than our current standards, our current chemotherapies that we have to offer patients. So that opens the opportunity not just for more patients to benefit, but potentially combinations which may even increase the benefit because the agents are more tolerable than what we've dealt with before.
So Eric, let's turn our attention to the agent nivolumab that has phase 1 experience and phase 2 experience, and summarize for us your understanding of those results and how they apply to the choice of the pivotal trial in the phase 3.
So Bob, as you know, as having been one of the people that developed high-dose IL-2, one of the striking differences in terms of the nature of response with immunotherapy and the things we're looking for is this prolonged, durable response. So when these agents started to be used in renal cell carcinoma, nivolumab in particular, people were very interested in seeing what type of response would be seen. The first thing that was seen is that in terms of the phase 1 data, this was well tolerated. There were side effects like pneumonitis, which has to be watched for very carefully. But then if you look at the data that came out in terms of the spider plots looking at the outcome over time, the type of response over time that was seen in the phase 1 study, people were really excited in the 34 patients that were in the phase 1 data set to see that there was that subset of individuals who had dramatic and prolonged responses. And so that was really, really heartening data for us. At that point in time, the exact dose, and I think we still probably don't know exactly what the perfect dosing is for these agents. A larger phase 2 study was then done looking at dose ranging, 0.3 milligrams per kilogram, 2 milligrams per kilogram, and 10 milligrams per kilogram. And this is in the JCO. It was published late last year. Mm-hmm. And in this study, some very interesting results started coming out. First of all, in terms of response rates, the response rates were modest, but by RECIST were not in the 70 to 80% range. The progression-free survival also was relatively modest, so we saw a 2.4 to 4-month progression-free survival. But what was really interesting, again, is, as you see in the paper, there are individuals who have profound and prolonged responses that are persisting. And the other thing that's really interesting about this study is that if you look at survival, you see that the overall survival in the 2 higher dose cohorts is in the 25-month range. Now, these are previously treated individuals. So that type of response and that type of survival actually seems to be a bit of an outlier. So these early data already in this phase 2 study, I think are causing justifiable excitement for the utility of these agents in renal cell carcinoma.
So if I could summarize a little bit, seems to be safe, seems to have a subset of patients that clearly benefit, seems that PFS may not be the best measure of the success of the agents, and survival for some of the patients may be very encouraging. So Tom, clearly in oncology in 2015, the thing that we spend a lot of time talking about is there a biomarker? Can we enrich to identify the population of patients most likely to benefit? Have we had any success in that regard with respect to the checkpoint inhibitors?
Yeah, Bob, absolutely. So that's an area of ongoing research. And what we know so far is what David had mentioned, this PD-1 or program death 1 on the T cells, it is going to interact with the tumor PD-L1. And so we can actually stain tumors for this PD-L1. And the thought being that if a tumor expressed that at high levels and stained positive for that they may be in a group of patients that may have a greater response. And although we see a little bit of that, there's not a direct correlation between PD-L1 expression and response to the therapy. There's some, and so we certainly need to understand that better.
So David, do you think that the search for a biomarker in kidney cancer is the same as a search for a biomarker in lung cancer and melanoma, or are we really different? Do we have to think about biomarkers and enriching populations disease by disease as opposed to approach by approach?
Yeah, I think the answer to that question is there are going to be some similarities and some differences. So as Tom mentioned, the PD-L1, which acts like a barbed wire for the tumor to prevent the T cell from killing it, certainly is associated with response, but it's not a good enough marker. It's an inducible marker, so it's not a mutation that's there in every tumor. It comes up when T cells recognize the tumor and then can go away. It also is not as stable as a marker. So a tumor that was sampled, 10 years ago may not have just the staining may be altered by the fact that it's been in storage for a while. So there's a lot of different variables. When we talk about things that, new directions in biomarker development, we're probably moving to a multi-factor model. So PD-L1 would probably be part of that model, but then you want to also look at the immune infiltrate. Are there T cells present in the tumor as well? Because it seems like data from melanoma suggests that if you have both PD-L1 on your tumor and T cells, CD8 positive T cells in the tumor, those patients are even at a higher likelihood of response. And looking at those two in combination may increase our ability to predict who's going to be benefiting. But in the case of kidney cancer, to get more directly to your question, we struggle with biomarker development across the board. And one of the reasons we struggle, as you know, is the tumor heterogeneity is so enormous in our patients. So sampling one piece of the tumor may give you a different idea of what's going on than another part, or the MET might be different than the primary. And that's going to definitely impact our ability to predict who's going to benefit. One clue in kidney cancer that might be helpful, we've seen in the phase 1 trials, is it seems like tumors that are high grade, particularly grade 4 and sarcomatoid features, their response rate seems at least as good, if not better, than some of the low grade tumors. Now that's based on very small numbers, but if that played out, well, maybe you could add tumor grade into the model as well, and that would be very exciting, because those are patients we struggle to treat with standard therapies. They tend to do less well. And the grade situation may just be a correlation between high grade and high PD-L1 staining, but it could also be a correlation between the number of mutations that are actually in the tumor. A lot of work needs to be done there, but it seems in other cancers, those with higher mutation rates like melanoma, bladder cancer, lung cancer, tumors that are associated with environmental stress that leads to mutations are the tumors that are most likely to benefit from this strategy. So we need to sort that out in kidney cancer.